That's why all this has to be done in a very open way, in a very intensive way, because the Commission, we did our best in the Parliament actually to shorten the procedure, given the fact that we started with initial status quo of, from the Council not accepting the change in the directive, not accepting any positive development. Then we negotiated, we tried to do our best. We tried to convince that probably there are not that many occasions when in the Parliament there are rapporteur and shadow rapporteurs which are taking more or less the line of the Council by anticipating their worries and trying to amend the directive in a way that it will work. Now, after doing this, after voting in the Parliament, after having the Commission willing to amend the initial proposal, there is a second set of, how to say, of gameplay by the national authorities by saying, okay, you have milded, you have changed, now it's so soft that we don't need it. We know very much that politically this is the game, and we can continue playing this game, but we are from the disadvantaged side, because delays of the change of directive and all the provisions being supported and put into implementation means that actually the national authorities are winning in something that they are already doing it. And what they do is delaying, which is a disadvantage for everybody. That's why I said, and everybody here was insisting on this, that we have to make a little bit tough for national authorities to deny the necessity of changes of the directive. There should be a pressure, there should be working groups, seminars, there should be direct call on national authorities and national governments and national parliament a little bit to get into the right track and to stop denying that there are problems and these problems should be resolved. And now is the right time for political campaign. But when I say political, not the political bodies. I mean the civil society political campaign. And this will mean that we are mature enough, all of us, not to play each of us from our position and from our stage, but all of us to play for the public interest. And that's why it's the right time for all stakeholders to call on national authorities, on national governments, to be a little bit more responsible and to stop with this game like we are children and we don't know what's going on, and when we say, oh, okay, it's too tough now, it's too mild, what stays behind it? Delays stay behind it. And this is against the public interest. So now, please, one more time, 100 times, I will not get tired to repeat, please call on the national authorities to stop playing this game, because there is only one argument that stays behind it. It's against public interest. Delays are against public interest. And transparency, it's against public interest.
I'll be short because many of my thoughts were already expressed by Antonia. Of course, we are receiving rather worrying signals from Council. It would be good to have someone who explain more detail, but I'm not sure if there is someone who can do this. If the Irish presidency is committed to try to move forward this dossier, or they will enter this play, this game that already Antonia mentioned. My feeling is that in the end it is difficult for the Council to block for good this. You remember that a similar game was played when the cross-border directive, healthcare directive, was taken into account. Of course, that was that has a bigger impact on the national budgets, on national behavior, on health systems itself than this directive, which of course give more predictability, give more certainty, have more competitive timelines, introduce some measures, but which is on a ground which already exists legislation. We have the directive from '89, I think, which already have timelines, which already have procedures. Of course, this is a good step forward, but it's not coming from to a non-existing legislation now. The big risk is that they will soften even more what the European Parliament already adopted. This is not the worst scenario because then we enter into negotiations. And I'm sure that we have good arguments and our representatives and everyone who will represent European Parliament will have good arguments in order to convince them to compromise in a way that this directive really is a step forward and make a difference. I will finish by saying that this is the case, this is the solution. We are trying to convince our national governments. My party is a governing party in Romania. The Minister of Health is one of my colleagues from Liberal Party. Romania, it's a difficult case because the last updated of the national list was in 2008, when the former government, Liberal government, left the power. But now we work hard on a health technology assessment in order to have the procedures and to have this update this year, because the situation is not at all normal. I believe other colleagues from other countries are working on their governments, and what Antonia said, that is important that civil society, NGOs, industry even, all the stakeholders put pressure on national authorities is very important in this stage.
Probably it's good also to mention that this directive, since the beginning, has been accused of being industry-driven and mainly covering the interest of the industry, because the industry will benefit from a quick procedure of reimbursement of their medicines. But it's absolutely wrong, because the final recipient of the benefit is the patient. And that's why it's exactly the right time for patient groups and organizations to intervene. And to facilitate you, we will send you a list of member states which are becoming not just born, but are trying to organize themselves to block the directive. And if it will help, please address them and raise your voice and bring some transparency in this lobbying process, and who is who and who will benefit. And second thing I would like to add, I have forgotten to mention, this is just to bring again evidence on the cynical background of some of the arguments. When we worked on the clinical trials directive, I noticed that the timelines for clinical trials, it's twice shorter than the timelines for pricing solely and for reimbursement as well, which means that the national authorities, which are deciding on safety and efficacy of products and are endorsing clinical trials and make out of these trials or they give the opportunity for the medicines to become registered and to be given to patients, it takes twice shorter the time for this decision than a solely administrative bureaucratic decision to put them on pricing list. Imagine. Nobody can convince me there is a real argument why these timelines should be longer, apart from playing with them, not to give an access to the patients to expensive and new treatment. And as regard to generics, then it's even worse. To my experience and understanding, to block a generic while existing to the entry of the reimbursement list is pure corruption. I'm sorry for saying this, but I don't see other reasonable argument to do so. Thank you.
Thank you very much. François Ye, you have worked a lot on this paper.
I'd like to quote the impact assessment of the revision proposal, which I found really very interesting, saying that for patients, the delays for originator medicines, the welfare losses due to this delay, the order of magnitude in monetary value, is up to 970 million euro per country and per year. So that's really very high amounts. And for member states, pricing and reimbursement delays do not necessarily represent a budgetary gain. And for the industry, there is a loss, so it means less for investments or viability of SMEs at stake, ranging from 35 to 100 million euro per medicine. So the impact of the delays can be measured. We've evaluated it at various occasions. It is very significant for our societies, for our countries, also in terms of economics. I think there is hope. A few years ago, I was listening to a presentation of an expert from an HT agency who was very enthusiastic because he was explaining his agency could decrease the time needed for an HT assessment from more than 406 days to 350 days. And I asked this person, but if a company submits an HT assessment or if you are requested to conduct an HT assessment within the time limits to decide on reimbursement, even with 350 days, you will always end well after the 180 days limit. And his reply was that he did not know there was a 100-day legal limit. He had always been requested reports from the agencies that decides on reimbursement, but they had never been informed that they have time limits to respect. But what is very encouraging, and UNETA is part of the effort, they are coordinating the task, the efforts, in order to respect the time limits and even to anticipate with the pre-submission possibility at the time of the CHMP opinion, that is 90 days in theory before the Commission signs the market authorization. So again, a possibility for member states to start earlier the pricing and reimbursement, 90 days before the decision, and then 180 days. In fact, they have more time than in the past to do the same task with more efficient coordination represented by the technical and scientific work of UNETA. So I think hopefully we will have less and less cases of times and pricing and reimbursement decisions that are beyond the time limits.
Thank you. Salvatore.
Thank you. I think your question was extremely legitimate, and at the same time I would reject a plan B because I wouldn't like to enter in a kind of self-fulfilling prophecy. So if we talk about a plan B, it's as if we would to some extent encourage those detractors to come to an agreement. There is a cost of non-transparency. So we had in the mid-80s the cost of non-Europe. Here we are talking about the same thing. There is a cost of non-having any agreement on the revision of this directive. This directive is about real life. And is about, I would say, a combination of discipline and flexibility. And just to use this image, maybe now the balance is disproportionately in favor of flexibility. And we have a bit lost track of discipline. So the fact that, for example, some operators in the area don't know about the deadlines is rather indicative of the fact that these deadlines are not so much respected, at least not so much as they should. So I think that now we have to find, again, a new balance between discipline and flexibility. For cultural reasons, I'm in favor of this flexibility, as we can imagine. Rigidity can never, I think, achieve the objective that we have. At the same time, there is, let's be frank, a kind of reward of not having an agreement for some of those who are discussing about the directive. If they don't comply necessarily with the directives, the deadlines, at least not in all occasions, then that's good. We can continue like that, because at the end of the day, we are not subject to very strict rules, to deadlines. We don't have to modernize so much our system. So this is a reward. We have to compensate this reward in terms, I would say, first of all, of economic consideration, So what would be the consequence for the industry? I start from that because we are in a period of crisis, so maybe this is an argument which is rather strong. And I think that those who are detractors and who are not in favor of an agreement for whatever reason should assume this responsibility of not contributing to an element of competitiveness of our industry. There is a cost for patients, because patients will have less access to medicines, and I think that it is something which has to be put on the table to say to the national interlocutors, listen, are you ready to assume this risk in terms of both industry and patient cost of non-transparency? And therefore I think that this kind of political consideration should counterbalance maybe the more immediate reward which is linked to this excess of flexibility that we are experiencing nowadays. So I think that without being too rigid, because at the end of the day, industry also and patients also need some kind and some degree of flexibility, and the contractual agreements, I think, are a very good example about that. We have to come back to a culture and to a habit and to a daily life which is much more based on discipline for all of us. I think that all actors should then assume the consequences of that. But I think that there is a price, both in economic and political terms and in social terms, that has to be put on the table to say, listen, okay, there is a reward of non-action, but there is also a cost. And of course, if altogether we manage to show that the cost from an economic, social, and economic point of view is much higher than the very short-sighted benefit that one can get from the non-agreement, maybe some arguments will become a bit more motivating to, at the end of the day, show goodwill and agree on something which should be viable, of course, because otherwise we should avoid, as Mr. Padova said, the tricky tactics whereby before, at the beginning, the directive was too ambitious. Now it's not ambitious enough, so why having it at the end of the day, which is what they are looking for. Not all of them, but some, maybe, yes.
Well, I have a mic, so okay. In your presentation, Salvatore, I noticed the need for a reply with verified or well-established reasons in case of a negative outcome, I suppose, or in any case. Is the transparency so that we could have an inclusion of a consultation among patients or patient representatives in the process somehow?
There are two different issues, I think, in this respect. There is a general obligation of consulting interest parties, and notably patients' organization, whenever there is, I would say, a major horizontal initiative at national level. And I think that here, realistically, the European Parliament has limited the scope of this provision, which is Article 15 of the proposal, by limiting that only to legislative initiatives taken at national level, because it is true that also from a practical point of view it would be extremely difficult to have a consultation, a full consultation on all the draft national acts, legislation, regulation, administrative acts, decisions. I think this would not be tenable from a practical point of view. And we can follow this approach, provided that, of course, there is a proper consultation, including of patients' organization, whenever a new legislation is being prepared at national level. Then there is the question of the consultation on each specific application. And there I think this is something which would be, I think, rather difficult to define at European level, because each member state has its own ways of proceeding. And also, I think you will not be interested maybe in all cases of an application, but just in some of them. I would not exclude that, of course, but I think this has to be weighted maybe on a case-by-case basis. Maybe it should not be excluded, but I don't think it should be imposed neither, because it would maybe make the machinery too complex and too burdensome for all parties, and this might also maybe scare the national authorities in terms of practical management of the daily administration.
I'll now open the floor for questions and comments. Jan Lecan, please present
Just
yourself.
to to launch the discussion, I will be the first. I'd like to go back to one of the key points that you made, and in fact, which relates to discipline, which is about the reassessment of data. And I'm very glad that you have these new amendments about the non-reassessment, because as Richard Bergstrom was mentioning this morning, with the growing complexity and fragmentation of the HTA and pricing negotiation process and reimbursement process, we are ending up in a situation where the local authorities, the national authorities, are basically challenging the scientific opinions of the scientific committees of the EMA, as if this opinion of this EMA were opinions of the others, of Europe. But it's their opinions. The way EMA is working is through the National Medicines Agency, so they are parts of the scientific opinions, which after that is transformed by the Commission into a decision, and they are also part of that decision, and then they deny it. And there is so many meetings that we are going to where we hear that the fact of rarity is not being recognized by this HTA, for instance, or at the moment of discussion on pricing, but the fact that the absence of alternative therapies, or the fact that there is significant benefit based on efficacy or on safety, on major contribution to patient care, is being denied. They are very skeptical. Yeah, it has been assessed by COMP, but I don't care. That's basically what they are saying. And so what you're doing with these amendments is very important, because it will bring in disciplines and clarification that there is no need to duplicate the work at a different level. And on this base, then, there may be more chances that we are able to implement in an intelligent manner the clinical added value of often medicinal products, the CAVOMP that was referred this morning, or the MOCA, the mechanism of coordinated access with the European Transparent Value Framework. Because if initially, for instance, the prevalence is not recognized as a key criteria or the significant benefit, then there cannot be the European discussion on the European Transfer Value Framework to discuss the value of a medicine and discuss its price. Thank you.
And we have a question or comment on the third row. Please keep the mic close to your mouth and present yourself.
Alexander Mensik from Amgen. 2 questions, if I may. Would the Commission be prepared to go backwards compared to the existing directive? And if the Commission issue a revised proposal, would the Parliament then have to issue another opinion on secondary rating, or can there be a trialogue negotiation based on the revised proposal?
Very pertinent question. The reason why we're not going to accept all of the amendments of the European Parliament, as Vice President Tajani said in the plenary discussion, is because there are some, very few amendments, 1 or 2, not more, which would go below what is provided by the current directive. And from an institutional and political point of view, we are not ready to accept that, because we would like to make a step further and not backward. As regards the second question, I think that once the Commission has presented a modified proposal, then the ball will be in the camp of the Council, and then I think the negotiation will start with the European Parliament. I mean, according to my experience, more than 20 years of the Commission, it will also start informally. So there will be, first of all, an informal trialogue between the Commission, the Council, and the Parliament, with the Commission being the honest broker between the two. But in other cases, I've seen the European Parliament going far from the Council. In this case, the European Parliament is going towards the Council to facilitate their life.
Yeah, correct. Actually, this is a new procedure now, and we took a legal opinion from the legal services of the Parliament and also the Commission how to fasten it and how to make it faster. And once the Commission, and also we did one more step forward in the plenary. We asked formally for endorsement the Commission whether they to comment on the voted proposal. On the report, and then the Commission said that they are accepting the Parliament proposal, which means that we will not use 1 or 2 months to exchange formally letters, but immediately the Commission, after that vote in Strasbourg, could have started, and they already started, started the draft of the new proposal, or the old new proposal, or new old proposal. And once it comes and will be presented back to the Parliament, we will start informal negotiations. Meanwhile, we trust very much on the Irish presidency and their moderator and negotiating abilities, and then we will be ready for trialogue. But meanwhile, there is a little bit of time for civil society activities.
Yes. Further questions, comments? This is a very timid audience. Yes, François.
When we met with your predecessors at DG Enterprise in the 90s to discuss the Transparency Directive, it was clear that they were afraid to open the Pandora box. And the main fear was that member states would use that opportunity to try to expand the delay much more than the 180 days. Are we at least secure on that side that there will be no attempt to prolong the delays even more longer than they are to make their job easier?
I can reply, of course, as far as the Commission is concerned, this is absolutely a clear red line for us, so we will never accept, from our point of view, to go beyond these limits. But let me maybe remind you that we talk about timelines, deadlines, but it's not only about this, it's also about quality of the deadline, because now deadlines are not defined in a very clear way. So now what we are trying to do is also to define which is the starting moment and which is the end moment of the delays, which for the timing is rather blurred, and each country applies its own criteria. It's about the moment of the decision, it's about the moment of the application of the decision, it's about the moment of the entry into force of the decision, and this of course might create discrepancies and different delays at the end of the day. So we are also looking at establishing clear and common definition to that extent. And of course, if we manage to have a better implementation of the current deadlines, this would be, I think, a great success, irrespective, of course, of generics, which should be treated in a much faster way compared to the originators, of course.
Actually, according to our information, sniffing around and talking to different representatives from different member states, there is not that much objections against 180 days or 90 plus 90 for the originators. There might be an attempt for generics, because the initial proposal of the Commission was 15 days, then the Parliament increasing it to 30 days. There are some national authorities that would suggest 45 days because of some national arrangements and the way they publish it in the official national journal. But still, especially for generics, imagine if you have in the reimbursement list originator with well-established use. What's actually the reason for delaying it while you just replace an expensive drug with the same but cheap drug? I don't even think that 30 days it's needed, but still, because the national journal is issued in those countries in which is the case, is issued once per month, it might be reasonable to say that 30 days is enough. 45, to me, it's, how to say, market bargaining.
Thank you. We have
Good morning, Ken O'Reilly from Biogen IDEC. Please excuse my hoarse voice as well. I just have a question on your comment about the civil society input to prevent delays. How willing and able, and could you comment on the capability of civil society to input into this process to prevent and mitigate any delays?
We'll give an example with other campaigns which were rather successful, and that's why I will say that I trust very much the civil society and the pressing power of the civil society, because when we started in 2007 a campaign on patients' rights and cross-border directive, nobody actually believed that it will be successful. And we did it in a very simple way. It is a matter of how stressful you press the civil administration, in a positive way, of course. And we started a campaign with the patients' organizations across Europe by preparing for them a template of a postcard and encouraging them to bombard the Commission, because at that time it was the Commission. Sorry, sometimes, you know. To bombard the Commission with these postcards demanding for patients' rights legislation. And it happened because they did it with about 2 million of postcards. We blocked the post services of the Commission, more or less, but it was very encouraging. And imagine, we started the campaign, we designed the campaign in February, started in April, and by September the Commission was done. So they came up with the legislation. And that's why I'm saying I rely very much, because here we are not talking about unreasonable, just mumbling and inspiring of civil society or unknown subjects. We are talking about people which have the right to demand the legislators to speed up. And don't want to refer even to the Lisbon Treaty on citizens' initiative, etc., etc. But this year is actually the citizens, the year of the citizens. So at least the Commission respects it, organizes rounds of different events. The Parliament respects it, and we constantly negotiate and invite different stakeholders, and we very close work with the civil society. So the Council should be also a little bit proactive and to deliver, at least during the year of citizens.
If I could add some additional short points. I believe in general the civil society has to play an important role, and in many occasions they really influence the final decision. But in this case, it's even more important, because here we talk about a very delicate issue, which is health, very important and very delicate in every member state, everywhere. Second, we are talking here about a political decision, so it's not something very technical. It's not something that could be interpreted. It's a political decision if the member states will decide to have a better system, a more transparent, a more predictable, with a lot more speed that we have today. If the decision remains to the representatives which are very much influenced by the national authorities in the field of drug administration, like the National Agency for Drugs, of course that the reluctance is quite high, because this will change the way that they are behaving now, their habits, their way to see things. And also, of course, if some bureaucrats are thinking that this will increase the expenses, they will be very much against. But if this issue will be a public debated issue, if other politicians than the state secretaries or the president of the drug administration, but also other members of parliament, prime minister, ministers, will be very much pressured to give an answer, and mainly by patient organizations, by media, by NGOs, not necessarily frontline by industry, even that it's legitimate that industry could put a pressure here too, because they invest money, they provide medicines, they want a predictability. I believe that the chances that these states will change their mind is much higher, because it's a political decision. It's not that we have two options, this is better, this is not, we have to see what is the impact. It's a political decision to change the things that they are today and to make them more transparent.
One of the means that Eurodis has in order to influence policy in member states is to benchmark between member states the situation. I was a little bit worried, if I understood correctly, that you have gone a bit backwards on the monitoring mechanism as to the implementation. Now I'm flying high. I know that I'm a bit in the balloon. I hope the directive will be approved and come through in very much in line with what you have presented this morning. But we'll need some kind of data collection on how actual access will be provided in member states. do you feel comfortable with how we are going to monitor this in the future?
I think that if the proposal goes through with the amendments of the European Parliament, we will get a huge added value compared to the current situation, because we will get more information not only about the situation in member state, but also about voluntary agreements, for example, some basic information, some realistic information which would not hinder the added value of these agreements. And I think that the solution found by the European Parliament is rather well balanced from this point of view. So I think that in terms also of not only transparency in bilateral relations between the applicant and the competent authorities, but also in terms of public transparency, the added value of the proposal would be huge from this point of view, definitely.
You have a comment? Yes.
Adam Heathfield from Pfizer. So I just had one question about international reference pricing. So I know that the directive is aimed at setting timelines and not trying to dictate practices about pricing and reimbursement in member states. But one of the issues which causes us as industry quite a lot of difficulty, particularly in the world of orphan drugs, is about countries referencing other prices in other countries, especially where there's very different wealth in willingness to pay for medicines. But that rests, of course, on prices being available in member states. So it stages and staggers launches and spreads out the timelines. If all countries have to meet the strict timelines under the directive, is it going to be possible for international price referencing to continue? Has that come up in your discussion with member states, that some of their current practices will be more difficult to implement if they all have to meet strict timelines? Has that been part of the debate at all?
No, frankly speaking, I don't see a direct link between the two things. I think that the external price referencing is something which is not covered by the directive. Of course, it's linked to that. But I don't think that there is an impact from the fact of having more clear deadlines, more transparency concerning other aspects, for example, the authorities, for example, the objective criteria which has to be used on one side and on the other about the price. Because this is something which is to be discussed and which is not in the remit of the directive. So I don't think that there is a link, at least a direct link between the two things. Yeah, and we are aware, by the way, in DG Enterprise, notably about this problem, and there are some reflection going on, but which is in parallel to this directive as part of a wider reflection, let's say.
Actually, it has not been discussed exactly in this relevance, but there have been some amendments, especially from the GUE group, which were more or less suggesting that there should be a price transparency at EU level, and there should be a EU price referencing system, but they have not passed. So there was, and it has never been discussed to be the scope of this directive. It's not the aim, actually, of the directive. Which does not mean that this discussion will not be held.
Yes, and we have one down here. Yes.
Hi, Mohit Jain from Biomarine. With a question, I'm intrigued, and one problem often faced is the definition for reimbursement, because decisions are made at a national level sometimes, but the decisions are very top-line decisions, which then go down to a regional level decision or a hospital level decision on access. So the relationship between access and reimbursements can be very weak at times. What's the scope, as you see, of the 180 days?
This refers, I think, to the general question of the scope of application of the directive. This is why I didn't mention that apart from the exclusion of contractual agreements, we were also proposing the exclusion of public procurements, which in some cases of hospitals, of course, are used. So these procedures would respond to other rules of transparency and other rules for the attribution of the contract. So they will not be covered by our directive. If we are mentioning the problem of duplication of procedures at regional and local level, there we agree this should be included in the directive, and this for sure is something on which we attach a lot of importance.
But wouldn't this then almost create the situation whereby an agreement can be made at a national level only to push the decision making down to a local level, so the 180 days actually doesn't mean so much, which happens often?
No, I mean, if there is an agreement, whether it is done at national level or at the regional level, doesn't matter. If it's a contractual agreement responding to the criteria of our definition, it will be out of the scope of application of the directive. Whether is decided at national level or at the regional level doesn't make a difference. Since it's a category which is excluded, then the geographical ambit doesn't make any difference.
Thank you.
But will the Commission be able to follow the differences in individual member states?
No. No, the thing is that we will have some kind of monitoring, but we will not be able to have a kind of registry where all the different agreements are registered. This is not, at least currently speaking, possible.
So you will depend on the vigilance of civil society?
Absolutely. We rely a lot on that.
Yes. Wills?
Thank you. So Wills Hughes Wilson, working for SOBI, but also chair of the Joint European Orphan Drug Task Force. It's really a comment, and I think there's obviously been a huge amount of work done here, and it's obviously not easy. But from an industry perspective, I think we can all acknowledge that there are challenges in access to orphan medicinal products. And however great the products might be that industry are developing, they're not really going to serve the patients if they don't actually get into the hands of the patients. So one thing I think that we are very grateful for is this idea of not reassessing the provisions of the robust EU framework for approving orphan drugs. I think from an industry perspective, we see often the core elements being challenged, the significant benefit. We have suspicions of artificial subsetting, which actually question the validity, as Jan has said, of the experts from the member states that are creating the system. So I think from our perspective, we would really welcome a consistent push to not reassess the elements that are contained in the marketing authorization, because we believe that that will enable us actually to focus on the real issues. And the real issues are the elements like the CAVOMP, the MOCA, the different collaborative processes that will take us to the next stage, not constantly looking back and reassessing decisions that have already been taken. So from our perspective, just thank you very much, and we hope that this makes it through, and we'll do whatever we can to continue to support that.
François, yes.
In direct relation to what you say, I think one of the difficulties is that some member states don't reject the significant benefit, just they need to quantify that benefit in terms of economics, and they are not reassessing it. It's just that they need to prove that it has to be a high-level therapeutic. It can be significant but modest, so that's why they need to quantify it. One more reason to integrate HTA experts much earlier in the process, in the early dialogue, and talking with the COMP members to integrate early in the development of the medicines what will be needed to quantify that benefit when they will have to evaluate it.
We hope, of course, that's what the CAVOMP will facilitate and will support. And you know that we have been very, very actively involved in that, and we will continue to support that actively via the trade associations, but I'm sure as individual companies too.
Thank you, Will. Yes. Further questions, comments?
Lunchtime, not very encouraging.
So I'd like to thank the presentators, in particular our rapporteurs, for the great work you have been doing on the proposal from the Commission. Thank you very much for the representatives' explanations. This has been, I think, yet another demonstration that we can achieve a lot by working together. and I'm very grateful for the commitment that we see from the European Parliament to make sure that European citizens suffering from rare diseases will benefit from what we can do together. So thank you very much. And now it's lunchtime.